So Dr. Eisenschenk joining you to talk about metabolic health, obesity medicine, and value-based care. So my story really starts 6 years ago in 2016 when I learned really about some foundational principles of metabolic health and obesity from a mentor of mine, Steve Park, obesity medicine physician in northern Minnesota. He talked about the impact of insulin as a chief hormone central to our metabolism and its role in de novo lipogenesis through my own journey. Shared more detail on a different video here. I'll call Food as Medicine Low Carb 101. I decided to transform my own diet, and I found remarkable benefits in many different avenues, and haven't looked back ever since. So briefly, the evolution of human nutrition. Really, we're going to just start here a few decades ago in the 1980s with the advent of the food pyramid, which as many of you know, was a response to increasing incidences of CAD and hypertension, or heart disease and hypertension, recommended without evidence to decrease the intake of saturated fat while promoting the ingestion of sugars and starches, particularly starches as listed on the bottom of here, this image, such as breads, rice, cereals, and pastas, in very high servings, per day, of amounting to 223 to 235 grams per day of carbohydrates. Animal protein was to be limited, and fats and oils were to be used sparingly. So on the surface, it's important to note that while these are, quote, healthy grains below the surface, these polysaccharides are all metabolized or cleaved into a shared common pathway of glucose, as demonstrated here. Glucose, of course, is blood sugar, and blood sugar in excess can cause many of the metabolic consequences that we're going to hit on down the road here in a few minutes. So again, these dietary guidelines recommend 225 to 325 grams of carbs a day, and if 5 grams of carbs is the glycemic impact of about a teaspoon of sugar. If we do some quick math here, this amounts to over a cup of equivalent sugar a day into a system, our metabolic machinery, which functions optimally at a single circulating teaspoon per 5 liters per day. And this is really a recipe for disaster, and is really central to many of the metabolic consequences, the pandemics of diabetes and obesity that we now see. We see the guidelines here starting in the 1980s. A decade passes, and we have the development of increased incidence and prevalence of obesity. Similarly, with type 2 diabetes and the progression of insulin resistance, we know that there's about a 10 to 15-year delay between the beginnings of insulin resistance via hyperinsulinemia and ultimately the downstream cascade of hyperglycemia, which is still when classically type 2 diabetes or prediabetes is diagnosed. We see this here. About a decade passes between the advent of the guidelines and a sharp rise in the US population having diabetes. So insulin is like our parents. It tidies things up. It wants to stuff energy away, store it. It's the chief anabolic or storage hormone. And I'm going to highlight just this last sentence here in red. It turns glucose, again, the shared common pathway of polysaccharide ingestion, into fatty acids and stores it as fat. Hyperinsulinemia is elevated insulin levels over time, primarily triggered by carbohydrates, somewhat by protein, and very little by fat. Elevated levels of insulin in response to elevated carbohydrates over time promote fat deposition, and particularly in places that are not naturally used to having fat, such as muscle, liver, and pancreas. And this cycle really continues of excessive carbs, of increased levels of insulin, of insulin resistance in the liver and the pancreas, and on and on. Tell my patients, and I want people to kind of reframe the way they think about insulin resistance as being a state of carbohydrate intolerance, and diabetes type 2 being a state of carbohydrate toxicity. Diabetes is, the link between diabetes and obesity is mediated chiefly via the effect of insulin resistance. This is from my med school pathology book, from 2007. This sentence is so critically important to our understanding of adiposity, of metabolic dysfunction, of diabetes. And, it's important that we know that, we don't die directly from this pathway, but its consequences. It's the branches of the insulin resistance tree of heart disease, cancer, stroke, Alzheimer's, diabetes, CKD, and now COVID. And this is shown here in this image of the trunk being hyperinsulinemia, insulin resistance, and the branches being modern chronic disease. So just a basic relook at metabolism and endocrinology 101. The goal of these these refined systems are to maintain homeostasis or balance. In Cushing's, for example, we don't ever treat that with steroids. We don't treat acromegaly with growth hormone or hyperthyroidism with levothyroxine. So a state of hyperinsulinemia, we shouldn't be recommending increasing or really any amounts of sugar or starch, much less exogenous insulin. It's only going to perpetuate the state of imbalance and asymmetric function and derail any homeostasis. So what is low carb, and why is this lifestyle, this way of living, enjoying nutrient dense, whole foods, low in sugar and starch, rich in fat and protein, a valuable tool and intervention in this process? Well, just briefly, it's not a diet. It's about reestablishing one's relationship with food, changing from a sweet to a savory tooth. It's about recognizing the importance of macronutrient quality, as well as it being part of this equation is certainly quantity, but we can't ignore the impact of the quality of macronutrients. A calorie is not a calorie in our metabolic systems. 100 calories of salmon or avocado versus 100 calories of bread or cookies have distinctly different cascades of impact. The nutritional carbohydrate requirement for humans to consume through our mouths each day is zero, thanks to evolutionarily developed pathways that allow not just survival, but us thriving in states of nutrient uncertainty. Gluconeogenesis and glycogenolysis provide the floor or the base to our cellular glucose needs. And the controlling insulin and promoting insulin sensitivity is key. And this can be accomplished via low carb, via keto, intermittent fasting, and certainly augmenting with clinically appropriate medications when needed on a case-by-case basis. So what does this look like? Well, here's an image from Diet Doctor of some delicious low-carb foods, low-carb beverages. And generally speaking, that carbohydrates are typically limited to 5 or 10% of one's daily calorie intake, or 30 to 50 total grams of carbs a day. Fat intake compromises a significant part of one's diet, and so does protein intake, as shown here. And one end of the spectrum, keto, is certainly more limited in dietary carbohydrates, and a more liberal low-carb approach on the other spectrum is maybe between 50 to 100 grams a day. As you can see there's a bit of sweet potato and some carrots, for example. Nutritional ketosis is a natural metabolic state in which the body is fueled by fats metabolized from fat stores via the liver into ketones, which many of the body's tissues and cells can use for energy. This occurs when insulin levels are low, typically when total carbs are below 30 grams a day. Fasting can augment this. The brain will happily burn glucose if it's available, but will also have can burn ketones as fuel as well. Nutritional ketosis can improve one's sense of energy, mental clarity, certainly can lower blood sugars and augments weight loss. This is not ketoacidosis, not ketoacidosis. Ketoacidosis is a different metabolic state that occurs at much higher and deranged levels of fatty acid oxidation in patients who have diabetes mellitus type 1. And this is not physiologically possible in cases of persons who don't have type 1 because of the presence of those of glucagon, allowing us to not completely become fat burning dependent, but always having a bit of sugar or glucose present in the bloodstream and having that balance. So we can test for ketones via breath, blood, or urine, but these are all optional and not necessary. Cooking in low carb, what does this really look like? Well, it looks like, utilizing resources, expanding one's knowledge and cooking repertoire and skills via cookbooks or many of their delicious recipes listed online, such as Diet Doctor. Planning and having intention with one's weekly meal routine with your spouse and family. This is my wife and I communicating a few years ago about our weekly meal plans, messaging back and forth, deciding who's going to purchase and cook these things, and going to the grocery store, making it at home, and then enjoying it with our family. What better outcome can we have in addition to the way we choose to live and eat than to share these and model this with our children? Why do low carb diets work? Well, the increased intake of satiating proteins and fats is key. Real foods taste great. This is not a fad diet. This is the ultimate human diet. Controls hunger and cravings. particularly sugar cravings over time, increases nutrient density and food quality, eliminates the most fattening food, which are sugars and starches, stimulates and allows a state of lipolysis or fat breakdown, and finally, often allows us to carefully and cautiously de-escalate or discontinue medications that a person may not need, saving costs and side effects. What's the evidence? When we look at RCTs or meta-analyses comparing low carb to low fat, low carb is really hands down more significant for weight loss, for glycemic control, for markers of metabolic health. Sometimes LDL, and we'll get to this in a minute, can shift and change. Low carb improves all markers of metabolic syndrome compared to low fat, lowering blood sugar, lowering insulin, blood pressure, triglycerides, and increasing HDL, as shown by Finney and Volek here. What about LDL? Well, sometimes it stays the same. Sometimes it goes up, sometimes it goes down, but it's important to note that the quantity of measured LDL is important and is usually indirect based on an average clinical panel. It's the quality that also matters. So what we typically see here is a shift from a more atherogenic small dense LDL particle, or pattern B, to a less atherogenic, larger, fluffier, quote, LDL pattern, pattern A. This can be quantified with an NMR study. It can also be just assessed by looking at a shift over time of one's triglycerides typically coming down, HDL increasing. That's a good indicator that the LDL particle quality is shifting to a more favorable state. Let's talk about support for low carb. This is endorsed by the Obesity Medicine Association. So they say that weight loss is greater than low fat, useful for the control of cravings, blood sugar, insulin, as well as increasing HDL, lowering triglycerides, lowering blood pressure, and it may reduce the complications of diabetes mellitus type 2. It's present in the obesity algorithm shown here. From the ADA, really a sentinel endorsement from a couple years ago, ADA is saying reducing overall dietary carbohydrates for individuals with diabetes demonstrates the most evidence for improving glycemia and may be applied in a variety of patterns to meet individual needs and preferences, as demonstrated here in this consensus report. Locally within Minnesota here and Essentia, we have a vibrant and vigorous weight management department started by Dr. Park a couple decades ago, now co-led by Dr. Gustafson and myself. Low carb is really a standard and pillar of our care and supported by our consensus statements and specialty bodies, which we just mentioned from the ADA and OMA, and is part of our Obesity Medicine Association training pathway. Our awesome NP colleagues and PA colleagues, Deb, Rhoda, and Mel, are part of my team in Baxter and Brainerd. Founded and co-led the first low carb conference in Minnesota. In 2019, we had over 410 attendees, some world-class speakers, including Dr. Westman, the late Adele Heitz, Jenny Callahan, and Amy Berger, for a wonderful day for our community. Lots of education and cascading of lifestyle changes since then that have been powerful to see in the community. We have a pending grant that would help us launch virtual and in-person support groups. And I also have a very robust and kind of fun to share newsletter that I develop each month for over 100 providers and subscribers on all things metabolic health. So this is our team here. This is our weight management team in Essentia throughout Minnesota, as shown. This is the one-page summary of our clinic, our 4 pillars, including nutrition, sleep optimization, movement and activity, as well as restoration and stress management. Another pillar being medication therapy and bariatric surgery. So what is, and this is just more work I'm doing in the community, article that I wrote about prescriptions for low food, keto nights at local restaurants, article that I wrote about COVID and diabetes and obesity as being major risk factors for poor outcomes early in the pandemic. An article in the Minnesota Medicine Journal, as well as podcasts and other communications that I try to share with the community. So what does the Essentia Health Care pathway look like? Well, let's start with a referral. So Dr. Johnson here, for example, recognizes the need for one of his patients to better assess, understand, and optimize their metabolic health and weight. He will counsel and prescribe some initial recommendations and handouts to the patient here and put a referral in for our weight management department. This order goes in through Epic and handouts are provided and the consult is scheduled. Pre-consult, the patient is mailed a 5-page intake, soon to be virtual, and some baseline labs are obtained. At the 1-hour consult, we get anthropomorphic measurements, we review the lab work, talk about the patient's history, looking at their care through the 4 pillars that we discussed, and discuss goals and follow-up needs based on complexity. We get collaborative support from our PT colleagues, our local trainers, psychology, therapists, sleep medicine, and bariatrics when indicated. And finally, we routinely communicate with the primary care team. So this is me and my team going back to Dr. Johnson with updates and changes. And finally, we hope to, as I recently alluded to, develop small groups to facilitate a community, either online or in person, for our patients to share and understand their journeys with more support. We also look at expanding remote home monitoring options with weight, glycemic trends, and blood pressure. So a couple cases here. 62-year-old female presented January of 21, 285 pounds, an A1C of 7.5 on glipizide, Jardiance, metformin, and Effexor. We initiated therapeutic carbohydrate reduction without any medication augmentation. As of the spring of 5 of 22, she's down 43 pounds. A1C is 6.8. She's off glipizide, Jardiance, and Effexor. Her ALT is normalized. She has no sugar cravings. She estimates she's saving $200 a month in medications. Her shirt has gone from size XXX to XL, and she's able to walk her dog to the end of the driveway. This is her weight trends as shown in the EMR, and an average slope line trend overlying those office visits, demonstrating her improvements in her weight over time. Another 154-year-old female, 6 months after initial consult with therapeutic carbohydrate reduction, metformin, and in this case, a GLP-1 agonist added more recently. As of June here, this should be June of 22, she's down 89 pounds, 8 inches around the waist, remission of type 2 A1C of 9 to 5.5, LFTs elevated, demonstrating hepatic steatosis to normal, triglycerides down 50 points, reversal of sleep apnea off of her CPAP, control of hunger and cravings. She's much more active on a daily basis and is supported by her husband, who's down 23 pounds. And this is that trend line from initial consult showing at her peak weights to current 89 pounds over 6 months. So what does this mean in terms of value-based care? What is value-based care, and how does this framework, if scaled, serve as a possible tool to improve what we like to call the triple aim, in addition to the fourth aim, which I'll get to? So currently, we manage type 2 diabetes, obesity, and the metabolic sequelae that occur downstream with increasing visits, drugs, hospitalizations, with skyrocketing cost, debt to patients, burden to healthcare systems, burnouts to all that are involved, with disillusioned and disheartened, patients and many times staff. But potentially, as I've shown you here, we can optimize and reverse type 2 diabetes, obesity, and prevent many of the downstream costly consequences, allowing us to then discontinue medications, reducing visits, potentially hospitalization, saving costs, and also critically inspiring patients and allowing them to live with a renewed vitality. So some diabetic quality measures here within our system and potential impact. So, goal here is to have an A1C for our patients with diabetes under 8. Our goal is remission. A1C is under 6.5, if not under 5.7. Blood pressure goals here under 140/90. Again, our goal is normalization of blood pressures, ideally off of antihypertensives. Certainly tobacco-free, nicotine-free, tobacco-free living is critical, and this aligns with our behavioral and supportive approach. Aspirin and antiplatelet therapy, certainly supportive of that, less contraindicated. Same thing with statin therapy. So we can have an immediate impact on a significant part of our quality metrics. But we know that because 3/4 of our population, adult population, has overweight or obesity, 2/3 are pre-diabetic or diabetic, insulin resistant, and that 88% of Americans meet some criteria for metabolic syndrome. My team, obesity medicine specialists within, Essentia or even the state or country, can't do this alone. We need to educate and connect with primary care to help tackle the pandemics that I've shared here, and do so through the lens of value. So I've developed some choosing quote valuably highlights to share here that I think would be a key for those who care for adults and even children in the primary care setting to know and implement. The first being therapeutic carbohydrate reduction is the most efficacious dietary intervention for metabolic syndrome, diabetes mellitus type 2, obesity, and other manifestations of insulin resistance. Incidental fatty liver or mild elevation in ALT, typically indicating such, most often indicates the developing insulin resistance and should lead to counseling on the above interventions. Fasting insulin level, as assessed in the lab, is better than fasting glucose, and certainly is a more early indicator of insulin resistance, which is the pathological basis for what I've discussed so far. Number 4, when possible, use alternatives to weight-positive medications in patients who have metabolic syndrome, diabetes, or obesity. Consider adding medications to reduce appetite, weight, and glycemia, such as metformin or GLP-1 agonist. Screen all patients with metabolic syndrome, diabetes type 2, and obesity for sleep apnea, binge eating, night eating, as well as coexisting mood disorders, including depression and anxiety. And finally, obesity and type 2 diabetes are best managed with a comprehensive approach, such as the team that I am grateful to lead, but can also be done in the primary care world with attention to diet, activity, sleep, mood, optimization, medication therapy, and the use of surgical specialty support when clinically needed, occurring over the longitudinal care of one's life, and in many cases starting in childhood. And finally, the 4th aim, one that is very front and center to me, and particularly as leader of hospital doctors over the last 2.5 years here, is physician and provider satisfaction, or burnout. We know there's a necessary shift towards including this in our quadruple aim and adding provider experience and burnout to this spectrum. We know within Essentia that over half of the providers are burnt out. This is not unique to us. This is nationwide. And we know that an antidote to burnout is guiding patients to renewed vitality. This has been my own personal treatment for burnout, is being able to thrive and see the renewed beauty and joy and health from so many people I've had the pleasure to help care for. It balances out some of the challenges of the downstream effects of these metabolic consequences that I see so often in the ICU or the hospital, at which point reversal or a complete remission of them seems to be more of a challenge. This fits with our mission and purpose to engage and inspire people, reduce harm, and improve the health and wellness of our communities. For more on this, I encourage you to check out Diet Doctor in my podcast there, which is now up to 40,000 views. Here's some recommended books, including Why We Get Fat by Gary Taubes, Why We Get Sick by Benjamin Bickman, and an awesome cookbook by Maria Emmerich. Finally, I want to leave you with this, the most important question we're not asking our patients. What are you eating? Thank you for listening. Hope this was a meaningful lecture and really helps you better understand metabolic health, obesity medicine, insulin resistance, the foundations of what low carb living is, and how this is critical to the triple aim of value through the lens of patient experience, cost, reducing suffering and negative outcomes, while also inspiring and impacting healthcare physicians and providers like myself. Thank you.